to faculty members. I think many in the audience might know Shushmita Ahmed from operating with her, from working with her during the time when she was a fellow in the MIS service, but she has now joined the faculty. Her grand rounds will be as entitled about what we should all know about bariatric surgery. Her background, I don't know very well, quite honestly, but I do know from her CV that she graduated Phi Beta Kappa from UC Irvine in biochemistry, went to Stanford for medical school, stayed on at Stanford for her general surgery residency, and then moved the 60 miles here to UC Davis for her fellowship with Dr. Ali and that team. And I know that group was so impressed with her performance and so pleased to have her join our faculty group. I know Dr. Lee wanted to be here and he cannot be here for some personal family reasons, so he apologizes for that. Did I miss anything in the introduction, Shushmita? No? Okay, the podium is all yours, and thank you.
Thank you very much for that introduction, and thank you all for allowing me the opportunity to speak today. Let's open this up. My introduction to surgery was actually through bariatric surgery, and this is a field that makes me really excited to be a physician and be a surgeon, and I'm so thrilled to be sharing some of what I know with you today. I have no disclosures, and really, like my title says, my purpose for being here today is really to reach out to physicians and show them how obesity is a very systemic and pervasive disease, a chronic disease that physicians of all walks of life are going to come into contact with at some point or another. We're going to review the treatments of obesity as well as the indications for surgery, and look at some of the outcomes and the complications associated with the modern day bariatric surgery. And finally, we'll review some of the resources available for our patients with obesity. So why does obesity matter? And in order to explain this, we actually first have to define obesity. And obesity is primarily defined by body mass index. Now, a BMI of 18.5 to 25 is normal. 25 to 30 is overweight, and any BMI 30 and over is considered obese. And this can be sub-classified. So obesity class 2 and 3 are considered morbid obesity, so any BMI over 35. And the prevalence of obesity has been rising pretty rapidly. So back in 2011, only a quarter of the states in the United States had a greater than 30% prevalence of obesity. Contrast that to 2019. Now, 3/4 of the states have greater than 30% of their population falling under obesity. And currently, 42% of adult Americans are obese. And obesity affects these patients from head to toe. So going from pseudotumor cerebri causing increased intracranial pressures and ocular manifestations, all the way to gout and venous stasis disease in the feet. And so again, physicians of all specialties at some point or another in their career are bound to encounter the consequences of obesity. And obesity is a disease predominantly of inflammation. So in the obese state, there's increased immune cells that are present. There's actually a change in the adipocytes. So adipocytes decrease or block factors that normally decrease inflammation and also produce pro-inflammatory hormones such as leptin. These hormones and cytokines that are released then cause cellular changes and ultimately remodeling of various organs. And this manifests as the comorbidities that we see. One of the most prominent diseases that are associated with obesity is cardiovascular disease. So remodeling of the blood vessels and the heart will lead to hypertension, CAD, and major cardiac events such as MIs and strokes. And interestingly, this remodeling can even lead to increased risk of arrhythmias. A JAMA paper actually found that patients with obesity are 50% more likely to have atrial fibrillation than those not. Obesity is also a significant risk factor for fatty liver disease. So adipocytes and fat deposits in the liver can cause physiological and histological changes. And the non-alcoholic fatty liver disease is a spectrum of these changes, which can ultimately lead to non-alcoholic steatohepatitis or NASH. And like any other flavor of hepatitis, this can progress to fibrosis, cirrhosis, and hepatocellular carcinoma. And in fact, NASH is the second leading etiology of HCC that leads to liver transplantation in the US, and it's the fastest growing etiology of HCC in patients who undergo liver transplant. Similarly, NASH is the fastest growing etiology of chronic liver disease in patients who are newly listed for liver transplant. In our own patient population, we actually looked at fatty liver disease in patients undergoing bariatric surgery. And preoperatively, 70% had hepatic steatosis, 44% had NASH, and 18% had fibrosis. But I think the most interesting thing of all is that 83% of these patients who had fibrosis actually only had mild NASH. They didn't have an advanced level of NASH. And this suggests that there's a nonlinear progression from NASH to fibrosis. And I think this can be pretty worrisome for these patients because they have an unexpected trajectory. Several studies have also shown the association of obesity with cancer. And one study actually found increased risk of esophageal, kidney, blood, and postmenopausal breast cancer in patients with higher BMI. And in a subgroup analysis, men who had a greater BMI were at increased risk of colorectal cancer. And this is especially important because colorectal cancer is already the second leading cause of cancer-related death in men. And of course, obesity can increase the risk of infection as well as the outcomes after infection. And we saw this with the H1N1 infection several years back. Patients with obesity were at increased risk of both hospitalizations as well as death following H1N1. And this is especially relevant in the era of COVID. If you look at the CDC website, the page for overweight and obesity information, at the top of the page, they list obesity as a risk factor for COVID-19. And the data is still limited, but we're actually collaborating with Duke University and Brown University to further look at these effects and the mortality of COVID-19 in patients with obesity. Now, what about patients who actually don't have any other comorbidities, no diabetes, no hypertension, etc.? Are these patients also at extra risk? And the answer is yes. So even in these metabolically healthy patients, there's an increased risk of cardiovascular disease, cardiac events. And in fact, for every 5-point increase in BMI, you actually see a 30% increase in overall mortality. I think that's pretty significant. So you would think in such a population with so many illnesses and comorbidities that there would be additional resources for these patients in the medical field. But unfortunately, this isn't the case. So we looked at a study looking at clinic visits in patients with normal weight, overweight, and obese patients. And we found that patients who were obese, especially those with a BMI of greater than 40, were less likely to receive essential diagnostic tests such as mammograms or even exams such as pap smears, pelvic exams, rectal exams, and skin exams. Obese patients were even less likely to see physicians. They were more likely to see advanced nurse practitioners during these visits. And this population was more likely to be referred out to other physicians. And part of the reason for these disparities, I think, is actually the resources in the primary care setting. As you can see here, regardless of BMI, all patients saw their primary care practitioner for about 20 minutes. And when it comes to patients with higher BMI, they're given additional health educational services. That means education about weight loss, education about nutrition. And so in addressing these weight-related problems, a lot of other essential preventive care is missed during these visits. So let's talk about the treatment of obesity. And when we do that, we have to look at weight loss. And this can be measured by either percent total weight loss or percent excess weight loss. And percent excess weight loss is essentially the amount of weight that's lost over a patient's excess weight calculated from baseline weight minus ideal body weight, or in our case, we use a BMI of 25. Now, the first line treatment for obesity is, of course, medical weight loss, intense diet and exercise regimen. But having a substantial amount of weight lost and sustaining the weight loss can be very difficult for these patients. Now, again, obesity is a chronic disease, just like diabetes, just like hypertension. So when medical management fails, or when diet and exercise fails for diabetes and hypertension, we escalate care. And I think a similar attitude has to be taken with obesity. So what are the advantages of surgical weight loss? As you can see here, patients who underwent surgery had a significantly greater weight loss than those who had intense medical intervention. And when we look longitudinally, these patients who underwent surgery actually kept off the weight for a longer period of time. Similarly, with comorbidity remission, studies have shown improved hemoglobin A1C, blood pressure, lipid profile to a higher degree in those who undergo surgery rather than those who have lifestyle modifications and intense diabetes medication management. So let's look at the options for surgery. First of all, who qualifies for surgery? In 1991, the NIH established some guidelines, and the following criteria were developed. So patients qualify for surgery if they have a BMI of greater than 35 with comorbidities, or a BMI of 40 or greater without comorbidities. And the most common procedures currently performed are the sleeve and the Roux-en-Y gastric bypass. And that's pretty much what I'll be focusing in on our talks, because this is what we perform here at UC Davis. So gastric bypass was first really developed in the 1960s when Edward Mason was doing partial gastrectomies for duodenal ulcers. And he saw that these patients, he and Dr. Ito actually saw that these patients lost a significant amount of weight. Unfortunately, these patients gained back a lot of weight, and they had problems with bile reflux because they had a loop gastrojejunostomy. So further iterations of this operation actually reduced the size of the pouch and transitioned from a loop gastrojejunostomy to a Roux-en-Y configuration. The gastric bypass has both a restrictive and malabsorptive component. The restriction coming from about a 30 milliliter pouch, and the malabsorption coming from the roux limb, which is typically 75 to 150 centimeters. I'm going to skip over the band and the duodenal switch just for the sake of time. The sleeve gastrectomy was actually introduced as the first step to a multi-step procedure for patients who had a BMI of greater than 60, because these patients are very difficult to operate on. But they saw that the weight loss was so significant in these patients that by the 2000s, this became a standalone procedure. And as you saw, it's one of the most common procedures that we see, the most prevalent procedure that we see in bariatric surgery. Laparoscopy was adopted in the 90s and the early 2000s, and it really revolutionized the field, because now we were able to offer safer and safer surgeries and offer surgeries to more people. And it's become the standard of care for bariatric surgery. So I touched upon a little bit of the restrictive and malabsorptive portions of the operation. Again, sleeve gastrectomy is what we consider purely restrictive. But all of these operations have a metabolic component as well, and this can be a talk in and of itself. And that's because we actually see physiologic and metabolic changes in these patients even before there's a substantial change in weight. And so there's a very strong metabolic component that we don't completely understand, and that's the impetus for creating the Center for Alimentary and Metabolic Sciences here at UC Davis. Now everybody wants to know about postoperative outcomes, so let's look at that. The Roux-en-Y gastric bypass is one of the best operations for weight loss. You get about over 30% total weight loss within 1 year after a bypass, compared to 25% with the sleeve gastrectomy. Again, sleeve gastrectomy is still a really great weight loss procedure as well. In terms of percent excess weight loss, that's about 60 to 75% excess weight loss for bypass patients, and 50 to 60% in sleeve patients. And these operations have excellent remission of comorbidities. Gastric bypass is a great operation for remission of diabetes, hypertension, sleep apnea, and GERD. And sleeve gastrectomy is also good for diabetes, hypertension, and sleep apnea, but it does increase the risk of GERD. Now, there's significant improvement in even biomarkers that are associated with cardiac risk. For example, this paper showed that there was an improvement in total cholesterol, triglycerides, LDL, a significant improvement within 1 year after surgery. And there's even a reduction in the inflammation, so CRP levels decreased after surgery. Metabolic syndrome itself is associated with an increased risk of cardiac risk. And this group used triglyceride and HDL ratio as a proxy for metabolic syndrome and saw that this too had a significant reduction. I want to focus on diabetes in particular. Now, 80% of these patients have complete remission. That means they are off of all medications. And they have significant reduction in their insulin levels, hemoglobin A1C, fasting glucose. And again, a lot of these changes are seen within the first few weeks of surgery. During residency, we actually used to send patients home without their diabetes medications because they had such a quick turnaround. This particular paper looked at pre- and 2-month comorbidities and found that significant comorbidity remission occurred within the first 2 months, even though these patients lost only about 20 to 30% of their excess weight within those 2 months. So again, that metabolic component. And it's really why a lot of people are starting to advocate bariatric surgery more as a metabolic operation rather than a purely weight loss operation. And interestingly, there's even effects on the brain. So memory and anatomical changes in the brain occur with bariatric surgery as well. Now again, when we talk about patients with obesity, we're talking about a pretty sick population. And a lot of these patients who have end-stage organ damage will require necessary interventions. But there are BMI cutoffs for these interventions. And so bariatric surgery can actually serve as a tool to help these people meet surgical criteria. One of the most frequent referrals that we get are actually from the orthopedic surgeons because with increased weight, patients with obesity are actually adjusting their biomechanics to accommodate for the weight and habitus. And this leads to adverse effects on not only the native joints, but also, of course, prosthesis that these patients might get after surgery. So after joint replacement, patients with obesity are in increased risk for prosthesis failure, dislocation, as well as the usual postoperative complications as well. And so a BMI of 40 is the cutoff for these patients to get joint replacements. When we look at patients who have undergone surgery versus matched obese counterparts, we see that those who undergo surgery actually had decreased in-hospital complications when they had total hip arthroplasty, and both decreased in-hospital complications as well as 90-day post-operative complications after total knee arthroplasty. And amongst patients who had hip arthroplasty, patients who underwent bariatric surgery had decreased risk of revision as well as reoperation. Kidney transplant is another popular reason why surgery is used to bridge patients. Obesity increases the risk of proteinuria, decreases GFR, and all of the mechanisms that basically damage the kidneys preoperatively pose a risk on the transplanted kidney as well. And again, these patients are at increased risk of postoperative complications, and there's some evidence that in patients with obesity, the actual bioavailability of immunosuppressive medications is altered, and so the newly transplanted organ is at risk for immunological damage. And so often these patients are limited with a BMI of less than 35, and actually some centers will not do an operation on anyone with a BMI of greater than 30. When we look at the outcomes of patients with obesity after kidney transplant, they have an increased risk of both graft loss as well as delayed graft function. But after bariatric surgery, these patients have decreased risk of graft loss, decreased risk of mortality, and a decreased risk of long-term decline in eGFR. Again, this is important because you don't want these patients to have organs that are damaged after the transplantation. Now, just like recipients just like there's a risk to the recipients, there's actually a risk to living kidney donors who have obesity as well. So first of all, recipients who receive an organ from an obese living kidney donor, again, have an increased risk of graft loss. In terms of the donors themselves, these donors actually have an 86% increase in the risk of end-stage renal disease after transplantation. And obese living kidney donors have a 30% increased risk of long-term mortality compared to those who are non-obese. And the risk is such that actually there are some people who are starting to talk about bariatric surgery for these patients before they donate. I think one of the most unique collaborations that our clinic has is with the heart transplant group. And that's because these are very, very sick patients. Nobody else really wants to operate on these patients. But we're really committed to treating these patients and treating the obesity because it can have a significant outcome on their cardiac function and make them eligible for transplantation. Because again, transplantation is limited to a BMI of less than 30. And studies have found that sleeve gastrectomy is really a safe and effective bridge for these patients. One study looked at 7 patients with an EF of less than 25%, BMI of 40 to 43, and 3 patients underwent gastric band, 4 patients underwent sleeve gastrectomy. And those who underwent sleeve gastrectomy had a significantly improved EF. All of the patients lost enough weight that they met transplant guidelines. 2 were successfully transplanted. But I think most impressive of all is that 3 patients actually had improved symptoms in EF such that they no longer needed transplantation. And of course, we have limitations for elective surgery as well. As a general surgeon, we're self-referring to our own bariatric clinic because anyone with a BMI greater than 35 who has a large hernia is at increased risk of hernia recurrence. Even with the colorectal surgery patients, there's already literature in the cancer literature that shows that patients with increased BMI do worse after rectal cancer surgery. And a lot of these patients are limited from undergoing minimally invasive procedures. When it comes to elective colon operations, for example, for diverticulitis, there's not a lot of data, and so our own Dr. Leo and Dr. Raskin are looking at the role of bariatric surgery as prehabilitation prior to these operations. Now, there's risks with any operations. So how safe exactly is bariatric surgery? Well, again, with the advent of laparoscopic surgery, we've really been able to reduce the length of stay, have earlier feeding, and a lot of these patients do much better. Gastric bypass patients spend about an average of 48 hours in the hospital. Sleeve gastrectomies, 52 hours in the hospital after operation. And over 50% of our patients are actually being discharged by post-op day 1. I mean, that's better than some of our hernia operations. And starting 2012, bariatric societies actually compiled all of the data into one large national database with strict, rigorous monitoring. And that large amount of data from a large number of institutions has really shown that bariatric surgery is some of the safest operations out there. For example, for 30-day outcomes, when we look at the risk of leak, in both sleeve gastrectomy and Roux-en-Y gastric patients, the risk of leak is less than 0.5%. And with serious events, for example, PE, MI, sepsis, the risk is less than 1% for sleeve gastrectomy patients and about 1.4% for gastric bypass patients. When we look at any adverse event, and that is any event that's outside the norm, whether it's dehydration or ED visits for nausea, etc., along with the other complications, the risk of that is about 12% in gastric bypass patients and about 8% in sleeve gastrectomies. And the numbers are still very similar even a year out after surgery. And one of the most feared complications we have with the gastric bypass is actually internal hernia. And this is one of the most common consultations that our residents will get. And unfortunately, it really is a diagnosis that you need a lot of clinical suspicion for, because CT scans can only pick up about 50% of these cases, and the presentation of these cases is very varied. Now, the internal hernias occur because of mesenteric defects that are created at the time of surgery. So, for example, in a retrocolic configuration, we create a JJ defect, a mesocolic defect, and a Peterson's defect, which is the space between the roux limb and the mesocolon. You only have 2 of these defects in the anticolic, since we don't have a mesocolic defect. And many studies, and for a long time there was a debate on whether or not closure of these mesenteric defects impacted internal hernias. As you can imagine, if these spaces are open, bowel can get through and can get stuck, just like with any other hernias. And if you look at the literature for studies that actually showed closure of the mesenteric defect, the incidence of an internal hernia was actually less than 1%. So even though this is a very, big deal complication, the risk is very low. And one side note for our residents, if we catch this hernia, catch internal hernias early, the management is simply diagnostic laparoscopy, reduction of the bowel, and closure of the mesentery. These patients can go home as soon as 24 hours after surgery. However, if we miss this, then the consequences are devastating because these patients can have ischemic bowel, they can have short gut. And probably one of the most common anatomical complications we see is the marginal ulcer. And this is ulceration at the gastrojejunal anastomosis, typically seen on the jejunal side of the anastomosis. Typically, these are caused by NSAIDs, smoking, steroids, diabetes, anything that promotes ischemia. But still, most of these complications, most of the ulcers are treated non-operatively with high-dose PPI and elimination of the noxious stimuli. Finally, let's look at mortality. Fortunately, the risk of mortality with bariatric surgery is very low. So less than 1% at 30 days and about 0.4% thereafter. So I've shown you the risks and benefits of bariatric surgery, but I think the ultimate question is, are these patients who undergo bariatric surgery better off than obese patients who stay obese? And the answer is yes. So several papers are actually now comparing patients who undergo surgery and matching them with the obese cohorts, and they found that patients who undergo surgery have a statistically significant reduction in all-cause mortality compared to those who did not undergo surgery. And that was shown in both gastric bypass as well as sleeve gastrectomy. And you have to remember, this is all-cause mortality, so we're actually accounting for the risks that occur with surgery. So despite the added surgical risks, patients who undergo surgery are still better off than patients who don't. Other papers have shown that in addition to all-cause mortality, patients who undergo surgery, bariatric surgery, have decreased cardiac mortality compared to patients who remain obese. And they also have a decreased risk of de novo hypertension, diabetes, and that's important for all of those young patients who currently have obesity who progress in their disease. So I think the takeaway point here is that in those patients with obesity, it's actually safer. Patients have a greater quality and quantity of life when they undergo surgery rather than staying obese long term. Now, you would think a lot of people would then be signing up for surgery because there's so many benefits. But actually, less than 1% of eligible patients undergo bariatric surgery. I'm going to make this point again. Obesity is a chronic disease, just like diabetes, just like hypertension. If I told you today that less than 1% of diabetics actually got medication after failed diet and exercise, I think we would all be pretty enraged. And I think a similar attitude needs to be had with morbid obesity. So what are the barriers to surgery? I think the number one barrier to surgery is actually communication. When in studies looking at surveys of both patients as well as primary care physicians, they found that PCPs, 70 to 80% of PCPs didn't mention bariatric surgery as an option at all. A lot of these conversations were initiated by patients. But when patients did initiate the conversation, the majority of these primary care physicians were supportive. But even then, very few actually placed referrals. So why the gap? And I think that's because largely due to physician perspective. So a lot of physicians just are not familiar with the outcomes of bariatric surgery. They don't have a lot of experience. And they're depending on either anecdotal cases of complications or medical lore that bariatric surgery is not safe. And they question the long-term effectiveness of surgery. I've spent the duration of my talk talking to you about how safe surgery is and the benefits of surgery. And so I think it's really important for bariatric surgeons to have sessions like this where we can communicate and educate fellow physicians in the outcomes of modern bariatric surgery. Another reason that physicians don't refer is because they think that surgery is reserved for advanced disease. But again, with any other disease, the longer you wait, the worse it is and the harder it is to treat. And we can see this with comorbidity remission. So again, I showed you diabetes remission is excellent with Roux-en-Y gastric bypass. But the patients who have true remission, going off of all medications, and who sustain this remission are the patients who have shorter duration of disease and who are younger age. So we don't want to wait too long to refer these patients. Let's look at age alone. So patients who are over 65 years old. These patients, bariatric surgery is safe in these patients, but they ultimately do worse than their non-elderly counterparts. Now, not all elderly patients are the same. I think functional status has a lot to do with how, how old a person feels and acts. And so we actually looked at functional status and outcomes in elderly patients undergoing bariatric surgery last year. And we saw that patients who were partially or totally functionally dependent did worse than patients who were elderly and independent. So we thought maybe elderly independent patients do just as well as non-elderly independent patients. And that's not the case. Even with an independent status, these patients had increased risk after surgery, and in fact, an increased risk of mortality after surgery. So the final barrier I want to talk about is actually from the patient perspective, because patients always say, I want to try to lose the weight alone. And I think it's really important that we support our patients, but we have to give them the tools to make an informed decision. And I think without the discussion of bariatric surgery, the toolbox is incomplete. Obesity is a very different medical problem compared to other medical problems because of the hurdles and the psychological and emotional components of this disease. People who come in to get their gallbladder removed, they don't have a real big connection with their gallbladder. So after surgery, they can just go on with their lives. But that's not the case with losing weight. Whether it's medical or surgical weight loss, these patients have to redefine their relationship with food, and that can be hard because even in our society today, there are social implications for food. It can be love, it can be comfort, it can be just socializing. And that's a very hard hurdle to overcome. So when we let these patients go lose weight alone without the proper resources, we're really expecting them to overcome behavioral, emotional, psychological, and physical barriers that come with losing weight. And that's a big task. And that's really what our bariatric team was designed for, is to provide dietitians, advanced practitioners, our nurse navigators, psychologists, support groups, in addition to the surgeons. And we are all here to support the patients and provide them the tools for successful weight loss. Now, all of our patients will tell you that surgery is just one piece of the puzzle. Having long-term follow-up, again, with with the ancillary staff, and having strong communication is key to giving them successful weight loss in the long term. And, contrary to colloquial belief, surgery is not the easy way out because, again, the surgery is just one part. These patients are having to change their entire lifestyle, change their behavior, change their mentality. And we're just providing the tools to get there. Now, as with any other operation, these patients undergo a rigorous evaluation to see whether or not what procedure, if any, is the right fit for them. And sometimes referring physicians can feel anxious about referring a patient because they don't know if their patients qualify for surgery. But that's exactly why we're here. We're the experts, and it's our job to work with all of these patients to figure out what is the best treatment plan for them. So in conclusion, obesity is a very pervasive systemic disease. I think everyone in their career is going to encounter it. And bariatric surgery provides a safe and effective tool for weight loss and can often provide improved quality and quantity of life for these patients. these patients are very sick, and so bariatric surgery can actually be a bridge to helping them qualify for necessary intervention. And if there's one point I want you to take away from this talk, it's this. Patients cannot make an informed decision about weight loss without a discussion about surgery. I think that's absolutely crucial to give them a perspective of how to lose weight. And any physician, anyone really, can initiate this conversation with these patients, especially because, as I showed you, this is not happening as often as we want in the primary care setting. So it's up to all of us. And finally, the bariatric team is here as a resource for these patients because we employ a multidisciplinary approach to really provide these patients with the tools they need for successful weight loss, because it is a very difficult journey. Thank you very much.
That was, Dr. Ahmed, that was a wonderfully complete talk on bariatric surgery and obesity in particular and its profound influence. Has the incidence of bariatric surgery been stable in the country, or has it risen over the last 20 years?
I think that's a great point. So the number of operations that are being performed is actually rising, but again, despite that, we see that still fewer than 1% of patients are actually undergoing these operations, but there has been a steady rise.
Other questions from the audience?
I enjoyed your talk, and it's interesting that we're going to be starting this process now of research in metabolomics and so forth. So perhaps this old expression is especially appropriate, that an ounce of prevention is worth a pound of cure. Bariatric surgery hasn't and probably can't keep pace with the increasing incidence of obesity. But why is it that we have an increasing incidence of obesity? What's our understanding of that, and what can be done as a prevention, if anything? You know, how much of this is social? How much of this is our food sources? How much of this is portion control, so on and so forth, in terms of preventing the obesity to begin with? I think that, you know, from a public health standpoint, that's a really important question to understand.
And I think that's a really good point. So you're right that bariatric surgery isn't a prevention; it's treating the epidemic of obesity. I think, again, the epidemic of obesity is multifactorial. A lot of it does have to do with social. A lot of it has to do with socioeconomic. But I think there's also, again, this metabolic component that we don't truly understand. A lot of people have been looking at gut microbiota, for example, and seeing that there is a difference between the gut microbial environment in patients with obesity versus those without. And so I think better understanding the metabolic aspects of obesity in both patients who don't undergo surgery, as well as patients who undergo surgery, is a key element to both preventing obesity and making the treatments for obesity longer lasting.
Manny, any questions from outside?
Yeah, is there any data on patient satisfaction-oriented outcomes long-term?
What's the last part you said?
Is there any data on patient satisfaction-oriented outcomes long-term?
You know, I don't have the data, but, you know, as a medical student, I actually looked at quality of life a lot in these patients, and you can see the data. There's a significant improvement in quality of life as measured by several different surveys, SF36, et cetera, that these patients have compared to their pre-op status.
Yeah, go ahead.
So this is from Dr. Coleman. It was a great talk. What advice do you have for when we see hernias, ventral, inguinal as consults? Is it feasible to have a bariatric surgery first, then wait X amount of time for hernia repair?
Yeah, I think that's another great question. So Usually we don't have a cutoff for the inguinal hernias, but definitely for the ventral hernias, anybody with a BMI of greater than 35 does have an increased risk of recurrence. And again, as anyone who's done ventral hernias will know, doing a redo operation is very challenging, and the effects of a successful operation are less as you do more redos. I think it is extremely appropriate to refer these patients for weight loss prior to surgery, but anytime we refer patients for weight loss, especially when we refer patients for medical weight loss, we have to keep in mind a few things. Are these patients successful with medical weight loss? And will these patients get lost to follow-up? And often these patients can't lose weight in the given time that we have for them to come back and get an operation. And so these patients are really great patients to be referred to our bariatric center, because we can get them an operation and then eventually their necessary hernia operation.
Nice talk. I work at Shriners, and they keep on bringing up the issue of pediatric obesity surgery. So it's a little harder for us to understand. Is that something we should be doing medically or surgically? And what age do you start treating children? Can you change them medically, or do you start doing surgery at that age? And what's the effect of operating on a 12-year-old when they're 65?
Yeah. So in the pediatric population, surgery is actually reserved for post-puberty, because we want them to have the maximum amount of growth before they undergo these operations. Again, you have to remember that the kids that we're operating on are patients who are actually pretty sick and really have a lot of comorbidities. The effect of the operation is pretty successful in these patients. Again, just like we see with adults, there's improvement in quality of life. There's improvement in remission of comorbidities. So I think people are still studying when is the best time to operate on these patients, and is it safe to operate long-term on these patients. I think there's good data to suggest that it is an effective and safe operation. But, earlier to puberty, I think it's harder to say whether or not we should be offering these patients surgery.
So Dr. Raskin asks, is it difficult to obtain insurance coverage for bariatric surgery? This is a complaint that she gets from many patients.
I think Judy, our nurse navigator, experiences this the most, but actually a lot of insurances do cover bariatric surgery, and that was actually a push from physicians advocating for these patients. So Judy, anything to add for that?
We actually, we do put authorizations where we do ask a lot of our patients to go ahead and call their insurance company to find out if bariatric surgery is covered. They do have a weight management that is required for a lot of the patients. It's not like we just get authorization and do surgery. Typically, like Medicare requires 4 months of weight management. A lot of the PPO insurances require 6 months of weight management. That means seeing a dietitian or your primary care doctor every month for 6 months, 3 months, 4 months prior to having surgery.
But again, this is something that we supervise in our clinic. So when patients are evaluated here, we're actually following them during that period of time, or we can follow them during that period of time so that we can ultimately get them the operation that they need.
Well, I think you can tell by the number of questions, both from the audience here as well as afar, that it's a topic that everyone is quite interested in. As a society, we're quite interested in. I think all of us, particularly your partners, are quite happy that you're here with us. So, Dr. Ahmed, congratulations and thank you.
Thank you so much.